Sunny days certainly make us feel good, but there's a dark side. Those bright days can cause sunburns, wrinkles, and skin cancer. On this week's Health Talk, a dermatologist will answer common questions on sun protection and skin cancer prevention. So if you're wondering what the difference is between sunscreen and sunblock, or if you should wear sunscreen in the winter, stay tuned. Health Talk is up next. Today our topic is sun protection and skin cancer prevention. Our guest is Dr. Charles Halasz. He's a dermatologist on the Norwalk Hospital medical staff. Charlie, welcome to Health Talk. It's so good to have you.
Thank you.
This is such an important topic. It involves all of us.
Right.
And I know that I guess back in the Renaissance days it was nice to have pale skin.
Right.
But now the new millennium, we all want to be dark and tan and thin and look like. So what are the ups and downs of sun exposure?
Well, the good part of sun exposure is your skin makes vitamin D, and normally that's the way we get vitamin D. We can take it in vitamins, but not everyone remembers to take their vitamins. So you need a little sunshine to get vitamin D, but not too much, because the downside is you might get skin cancer, particularly if you're fair-skinned.
You know, I've heard that astronomical amounts of vitamin D with just fairly short periods of sun exposure. I don't remember the numbers. Do you have the numbers?
They say that in bright sunshine, say in Florida or even in the Northeast in the summer, 15 to 30 minutes of sun on your arms is sufficient twice a week to get an adequate supply of vitamin D. However, in the winter, in this climate, no matter how long you stay outside, you can't make enough vitamin D. So then you would need a supplement potentially.
So during the winter, you think most people should be taking supplements in addition, or are there enough supplements in our food to sort of, if we're
That's
eating
a great
healthy?
question. I think it's one of those controversial topics that you'll find people on all sides, you know, the people who poo-poo vitamins and people like me who do take all kinds of supplements. I think to be on the safe side, it's good to take a multivitamin or a vitamin D supplement, particularly in the winter. Mm-hmm. But I'm sure you'll find people who disagree with that. There are some foods that do contain vitamin D because it's added. Some orange juices have it, milk. But the average adult would have to drink so much milk to get 600, 800. You'd have to drink 6, 8, 10 glasses of milk, and adults don't do that. So there's some foods that have it naturally, like liver, and who eats liver all the time?
Or at all.
Right. So, and in the old days, we used to take cod liver oil. Some people still do that.
That sounds equally appetizing.
Right. I think they make it in capsules now, so you don't taste it, but it's still not popular.
So, and again, so many women are taking supplemental vitamin D and sometimes calcium for their low bone mass. So it is an issue up north here. But it is remarkable how much vitamin D you can get in the summer or in the south with limited sun exposure. Right. Now, again, my wife used to, I probably shouldn't say this, but she used to go up the top of her dormitory building in college, sit with a reflector in the spring and just soak up the sun so she could look a healthy tan.
Right.
Now as we get in our 60s and 70s, we're not so happy about that.
Right.
Maybe you could say something about the sun and aging skin.
Well, that's a good one. I assume she has freckles now, your wife, right?
Yeah.
Yeah. Well, we divide sunlight the ultraviolet light that comes from sunlight into different wavelengths. So the type of light that goes through window glass is called UVA, and that doesn't usually tan you from normal sunshine, but if you get hundreds or thousands of times that amount, it can overwhelm your skin and you will tan, and that's the kind of bulbs that you're exposed to in tanning salons. They use UVA bulbs. So that's not the natural way to tan, but you can force your skin to tan by going to a tanning salon and exposing yourself to UVA. But just as UVA goes through window glass, it also goes deeply into your skin, and it leads to wrinkling, amongst other things. So that's one bad thing. Then UVB is the shorter wavelengths that are usually stopped by window glass, and those are the rays that normally tan you, and those are the rays that we think predominantly lead to skin cancer by causing mutations in the DNA of your cells. So basically, the good part is the UVB leads to formation of vitamin D, but it also damages your cells in the long term, causing what we call photoaging.
Mm-hmm. And I think that's been an increasing realization that how wrinkled we are at 70 may reflect how
right.
assiduously we sunbathed in our 20s,
right.
teens and 20s. But let's talk for a second about
okay.
skin cancer. I think a lot of people think of skin cancer and sort of wiped out skin cancer. They've heard of basal cell carcinomas
right.
or small squamous cell carcinomas that are
right.
largely trivial. But that's not the only problem with skin cancer, is it?
Well, basal cell skin cancer and squamous cell comprise the bulk of skin cancers that are related to sun exposure, and there's an estimate of about 3 million cases per year. And so there's about a 1 in 5 chance of getting a skin cancer by age 70 for the average American. That's pretty high. But there's melanoma is another type of skin cancer, which is also related to the sun. That's considered to be the most dangerous kind. And there's a few other types. Not all are known to be related to the sun.
I was alluding to melanoma
right.
that I believe, well, the last I heard is that it was related to the number of blistering sunburns that you had during your teenage and early years.
Yeah, there's a theory to that effect, but it doesn't account for every case. So people who are fair-skinned, who have blonde or red hair, who freckle easily, who burn in the sun, but then the tan peels off so they're still pale, which is me. Those are the people that are more prone to melanoma and skin cancer in general. So you're absolutely right. Basal cell is thought to be due to, that type of skin cancer is thought to be due to prolonged sun exposure, say like a farmer. And then there's squamous cell is probably a combo. A lot of recent sun exposure can induce squamous cell carcinoma. And melanoma, it's not clear. Some melanomas are definitely related, at least statistically, to those sunburns. But occasionally we'll see melanomas in the back of the eye or in the lining of the brain where the sun never reaches, or the soles of the feet. So not every melanoma is from sun, but it's a major risk factor, sunburning.
And one interesting statistic I remember is that women often have melanomas on their arms and legs, on their extremities, where truncal melanomas on the chest and back,
right.
more common in men, sort of reflecting the way we expose ourselves to the sun.
Exactly. It's the clothing that we wear and where we're protected. And men get more skin cancer on their scalp with the thin hair that at least I have.
Yeah. Most of us get there. But I think that to distinguish for our, melanoma is not a trivial skin cancer.
No. The rate of melanoma has been going up year by year in spite of sunscreens, in spite of all this publicity. And it can be fatal if it's ignored. In most cases, it grows, and people think it's a mole, but it's growing bigger. And usually you have a year or two or more before it becomes invasive and becomes dangerous. So checking your moles is important from time to time.
I think that's a really important point to make for people, is that a mole that's changing in size or shape, certainly one that bleeds, but a mole, most moles are benign. And I know I had a lot of moles. I was terrified my whole life of melanoma.
Right.
But melanoma can look like a mole at the beginning, and that's when it can be curable.
It's indistinguishable. The estimate that I've read is that only 1 in 10,000 moles is likely to become a melanoma. But some people only have 2, 3, 4, 5 moles, and some people have 100. So the more moles you have, the more incumbent it is to have them checked from time to time. You can check your own moles. On your back, you may have to ask your doctor or somebody to check you.
There was a point in my life where I actually got skin checks from a dermatologist.
Right.
Is that something you recommend to patients with a lot of moles or family history? Or
That's a great question. Should you have a checkup by a skin doctor once a year? A lot of people do that. The government has committees that says that's not necessary, only in specific situations. But the American Cancer Society and other groups have different guidelines. So the way I see it is if you have a family history of skin cancer or melanoma, if you have a lot of moles, if you have a history of sunburns in the past, or you don't tan well, but you burn easily, certainly if you've ever had a skin cancer, in all those situations, you probably should be checked once a year by somebody.
Yeah, the point you made is that it's like certain other cancers, melanomas have a curable phase,
right,
where they are discoverable. There are characteristics of melanomas. We can actually, the ABCDs,
right,
which, and maybe we should go through those, that make you worry a little bit more about them. But they are curable. But once they start to invade and metastasize, it's, as an oncologist, it's a nasty cancer. It metastasizes everywhere. Until recently, there was very little we had to treat it with.
Right.
But it's very different than the squamous cell or the basal cell cancer.
Right.
Do you want to go over a little bit what would make a mole suspicious for people at home?
Well, there's the ABCD system that the National Cancer Institute came up with some years ago. So the A is asymmetry. If the mole is dark on one side and light on the other, for example, then it's asymmetrical. It should be checked by somebody. If the border is jagged, B is border, then that's another reason. Your average age spot or mole usually has a sharp oval shape. So if it's jagged or it's fading, that's B for border. C is a variety of colors. Your average mole is one color or one shade. But if there are multiple shades of color, then that's a little suspicious. When you start to get 4 and 5 shades within a mole, that's highly unusual. And we consider dark brown, for example, and medium brown and light brown or tan to be different colors or different shades. So that's important. Then D is diameter. So diameter, the keywords, remember, pencil eraser. If your moles are smaller than a pencil eraser, they're probably okay. And then we've added E for evolution. So that means if you had a mole that you remember was smaller than a pencil eraser, and now a year or 2 or 5 years later it's larger, that's a way without photographs you can remember that it's changed. Now, moles do change over your lifetime, but usually they're all changing about the same. So when you're a kid, you have moles. They may get a little bigger as you get older. And then they have a life cycle. They actually go away. So by the time you're 80, 90, 100...
I was going to say, I've been noticing mine disappearing.
Right, they go away. So a mole that's changing out of proportion to the way the other moles are changing, that's what you're looking for. It's getting bigger or darker than the other moles.
Well, I think that's important information for people. I can't believe we've run out of time.
Okay.
We'll have to leave sunblock versus sunscreen to another discussion.
Okay.
So we run out of time for now. I want to thank my guest, Dr. Charles Halasz, for joining me on Health Talk today and offering some great tips, some important information about your health. Please share your questions and comments with us. Call Community Relations at Nuvance Health at 203-852-2250. We'd love to hear from you. Thank you for watching, and don't forget to wear sunscreen and tune in to us next week.
Well, Thomas, you've got prediabetes. But with more exercise and a change in diet, it can be reversed.
I've tried exercising. It just makes me hungry for bacon.
I love bacon, too. And who really likes to exercise?
Not me.
Me neither.
Nobody. So we're good?
What? Oh, you still have prediabetes. Big time.
When I was 6, my dream was to make it to the NBA. When I was 6, my mom had a stroke.
I'm Paul George, and I want you to learn the signs of a stroke fast. F-A-S-T.
F, face drooping. A, arm weakness. S, speech difficulty. T, time to call 911. Because the sooner they get to the hospital, the sooner they'll get treatment. and that can make a remarkable difference in their recovery.
Protect the ones you love.
Spot a stroke, F-A-S-T, fast.
Psoriasis and eczema are common skin conditions which can be uncomfortable, unsightly, and annoying. When severe, these skin conditions can actually impair one's quality of life. On this week's Health Talk, a dermatologist joins me to discuss psoriasis and eczema, as well as to present the latest available treatment. So stay tuned, we're up next. Hi, I'm Dr. Eric Mazer. Joining me today to discuss psoriasis and eczema, as well as the latest available treatments, is Dr. Charles Halasz. He's a dermatologist with Norwalk Hospital, and thank you for joining me on Health Talk, Charles.
Thank you.
Well, Charlie, psoriasis and eczema. Before the show, I was just asking you, are these separate diseases? Are these a continuum of one disease? I usually think of them as separate.
They're separate. The psoriasis tends to be very scaly, red and scaly, and usually elbows and knees and a few other places. Eczema is more itchy, more red, not so scaly, and it's usually on the elbow creases, behind the knees, the neck, what we call flexures, right?
Is one more common than the other? Do you see both of them sort of in equal frequency in your practice?
I think eczema is really much more common. It's common in children. It goes along with other allergic conditions like asthma, hay fever, so it's one of the allergic types of conditions that are common. Psoriasis is estimated to be 1 to perhaps even 3% of the population, so it's a little bit less common.
And so maybe we should start with eczema. You talked about allergy and eczema.
Right.
Could you extend a little bit more? I mean, is this like hay fever, or is there a specific allergen that we can identify, or is this more an allergic predisposition in the patient?
I think some people just have a predisposition to multiple allergies. So in the spring, it might be pollen. In the fall, it might be mold. It could be the mites that are crawling around in your mattress. And then some people have food allergies, but those are less involved with skin. Or at least we think that's true.
So when someone comes to you with eczema, do you look for an allergen as a precipitant, or how do you approach that person? Let me ask.
Usually we try to get them feeling better from the get-go, regardless of what the allergen may or may not be. So we have various creams that we use. The traditional cream would be a cortisone cream, also known as a steroid, but now there's some newer creams available. To answer your question, when do we send the person to an allergist? When they're not getting better, when they may have nasal and other allergies, so it makes sense to send them over.
They said this is more common in kids?
Well, we start to see it in childhood, yeah, and it can continue on through adulthood, and we occasionally see people where they never had eczema or hay fever or asthma, and all of a sudden they're 50 or 60 and they're getting it out of the blue.
And then they're not young again.
No.
But eczema really has a pretty characteristic pattern of presentation, which is different than psoriasis. Maybe you could go through that again.
Well, again, the eczema tends to be on the flexures. People are itching, they're scratching. Sometimes there's blood on the sheets. And
nasolabial fold too.
Right. Sometimes kids are rubbing their nose; they'll get a little crease under their nose. But with psoriasis, it's more just the spots themselves.
Yeah. And psoriasis we hear about because of all the ads going on TV.
Right.
So maybe say a few words about psoriasis, because that's a very different disease, isn't it?
Right. Psoriasis, as I said, it's at least 2% of the population. And it's pretty much worldwide. It's hard to find any place in the world where we don't see psoriasis. So one of the theories now as to why it's so prevalent is that people with psoriasis may have a very active immune system. So if there were to be a plague or a TB epidemic, perhaps they would be less prone to get sick from it. But living in a modern Western society, there's no benefit to having this active immune system. But you can see that activity in the skin. The skin's all red and irritated. If it's on your hands may crack, make it hard to work with your hands. So there's a lot of research going on into what's activating the immune system.
Because it may be a full system disease. I mean, it may not just affect the skin, psoriatic. I was going to say a few words about psoriatic arthritis.
Right. As I mentioned, the immune system is very active in psoriasis. So not just in the skin. That's the tip of the iceberg. It can be in the joints. Estimate 10 or 20% of people with psoriasis will have achy joints. It can cause inflammation in the vessels of the heart. So there's an increased incidence of obesity, of diabetes, high blood pressure in patients with psoriasis. And that's become apparent in the last few years.
That's right. I know that for my whole life, you watch ads on TV and it always talks about boosting your immunity.
Right.
But boosting your immunity is not always a good thing. A lot of the autoimmune diseases we see are actually probably a result of overactive immunity.
Exactly.
Now, you said for eczema, a little bit more common, the creams are usually pretty effective, aren't they?
For the most part, yes.
But psoriasis can be more difficult to treat. Maybe you could say a few words about sort of the stepwise approach to treating somebody with psoriasis.
Well, with psoriasis, we also use cortisone creams. But we, in the last decade or so, we have vitamin D creams that are helpful, vitamin A derivative creams that are helpful. We used to use drugs like methotrexate for more advanced cases, but now we're using what are called biologics. Those are the things you see on the TV commercials, and they're really quite miraculous.
So in addition to the ads, they really do work.
They really work, yeah, and there's not too many side effects. There's at least 10 or 11 brands on the market now.
I'm literally overwhelmed by the advertising for these biologics for psoriasis, but it's a totally different mechanism. Maybe are they all tumor necrosis factor TNF inhibitors?
No, the first few drugs that were out were so-called TNF inhibitors. They included drugs like Enbrel and Humira, but now we have other so-called biologics that inhibit interleukins, interleukin 12, 23, 17. So as science gets deeper into what's causing psoriasis, we have more finely tuned drugs that have fewer side effects.
Now, for folks at home who, by the way, tumor necrosis factor does not mean anything with.
No,
it has this sort of a historical name.
Exactly.
It doesn't have to do with cancer. It has to do with inflammation, though.
Right.
And so what we're really saying is that these are designer drugs which interrupt different parts of the inflammatory pathway.
Right.
And help to shut it down.
Right.
But as a layperson, you say, well, I need my inflammatory pathway to react to certain infections and inflammatory. You don't see too many side effects with these drugs?
No, really not. I like to think of it as a pot that's boiling. Your immune system is overactive, so now you're taking the cover off and the foam kind of subsides. You still have plenty of heat in you. It's not like we're suppressing
You're taking the edge
immune
off.
system. Yeah, we're not suppressing sufficiently to cause much in the way of side effects.
But I think, again, these drugs are really a totally different mechanism. They're all intravenous, or?
Well, they're injected sub-Q, much like insulin is. Usually they come with an auto-injector, so you don't even see the needle, or it could be done in the doctor's office. The newer drugs are administered only every 2 or 3 months. So, coming to the doctor's office 4 times a year, your psoriasis is clear.
So did they work equally well on the arthritis of psoriasis and some of the systemic effects?
Yeah. Some of the drugs, the 17 blockers and the TNF blockers, overlap with what rheumatologists use to treat rheumatoid arthritis or psoriatic arthritis. So, there's a good deal of overlap
and they work.
And some of these drugs also can be used for other conditions like inflammatory bowel disease, that is to say Crohn's disease, for example, or ulcerative colitis, or there's another condition, hidradenitis. There's quite a few diseases that respond to the same drugs.
Yeah, and this, again, for folks, this is a whole new generation of expensive but effective drugs that are very different than the drugs that we've used conventionally. They
Right.
have specific targets in the inflammatory pathways
Right.
and are really turning off this overamped immune system.
Yeah, I think it's amazing.
Well, you as sharing our age,
Yeah.
it's really been pretty remarkable, the changes in drug therapy we've seen during our career.
Yeah, the medications we have are more effective and have fewer side effects.
Now, psoriasis can be a really, I said embarrassing, annoying, cause a lot of self-consciousness because it is pretty obvious, and it's, how often do you have to move from simple therapy to one of these much more expensive and complex biologics? It doesn't sound like they have more side effects, but they certainly are more expensive.
Well, if you only have a few spots, you probably can get away with creams. If you have some more spots, an older therapy that I didn't mention is phototherapy.
I was just going to mention that, actually.
It's still very, very effective.
I didn't know whether they were still using it or not.
I still use it, and it's very effective. It has essentially 0 side effects, but it requires going to the doctor's office 2 or 3 times a week, so not everyone has that kind of time. But so phototherapy's out there. If you start to...
Do you want to just tell me what that is?
That's where you're getting artificial sunlight treatments under a doctor's supervision, so we're very careful not to burn you, and so the risk of skin cancer is basically negligible from it, and yet it helps.
So sort of sequentially, you'd start with creams and topical agents, move to phototherapy if the patient can.
Phototherapy for the patient who's amenable to the time commitment, and for the patient who's not, the biologics that we were talking about are out there. So if you have 5 to 10% of your body surface area involved, which means elbows, knees, scalp, it's a fairly substantial area, then the biologics are a good choice.
You also hear about psoriasis being present, excuse me, in a small patch, but giving you the arthritis. Can you say a couple words about that?
Yeah, actually, you can have arthritis and all your blood tests are negative and you have no skin lesions at all, or maybe one little one that you don't even notice. But over the years, you may get more skin lesions, and then it can become apparent that you really have psoriatic arthritis, not just wear and tear osteoarthritis, for example.
So I've always heard as an internist, we should check in the navel, in the belly button, between the buttocks, in the scalp.
Exactly.
For
some
hidden
areas that you would be embarrassed to look, but yeah.
Yeah, but places where patients would certainly be
the private
unaware.
area, right.
And what percentage of your patients would you say need to go on to the biologics?
Relatively small, probably 1 in 10. That's a guess. Yeah.
And in terms of, again, there's so much advertising. I'm always surprised when you got so much advertised to focus on such a small group of people.
Me too. I never understood it either.
But do they basically all work? Are they basically all comparable in your mind? One mechanism versus another, rather than using name brands.
They're all excellent. It's hard to find one that's not good. With each year and decade that passes, they're marginally better than the, sort of like cars. They're a little better, but an old car is still good if it's running. Yeah.
So any final words? We've got about less than a minute left. Just on both eczema and psoriasis.
Well, I wanted to say that we have the same trend now with eczema. People who have bad eczema and also asthma, which is a related condition, now have a biologic available. I know I'm allowed to say brand names. Sure. Dupixent. Dupilumab's the generic name, and it's just a total miracle. The eczema clears. Dupixent is the brand name, and we're going to have competing drugs coming on the market soon, but they just wipe out the eczema. So again, we don't use it for someone who has one little spot.
Well, what's the mechanism? Is that another one of the anti-inflammatory?
Yeah, it blocks IL-4 and other interleukins that are now known to be involved in the pathogenesis of eczema and asthma.
So I think we really need to stay tuned because we continue to see the development of these new and very effective agents.
They're life-changing. I've had people who can't go to work because they're not sleeping at night. They have blood on their sheets every night. They're embarrassed to leave the house. And now I had one fellow, he started on the drug for eczema, and he got a new job in New York. He's a commuter now.
It's an exciting time for medicine, exciting time for folks at home. Unfortunately, we have run out of time. I want to thank my guest, Dr. Charles Halasz, for joining me on Health Talk today. Please at home share your questions and comments with us here. Call Community Relations at Nuvance Health, 203-852-2250. Thank you so much for watching.